Pooja, thanks for the invite. And my topic today, I think Pooja has told me to talk about is one of the toughest topics for me to cover after Harminder Dua actually has covered pretty much everything that needs to be said about PDEK. But I'll try and do justice to the topic because I think there is a reality that we had, a lot of years back. Dad and me had met Dr. Dua in a conference in Kigali that was in Africa, and that's where the whole game started for us. Where we actually came back, and I'm sure that if he does come back, he will have fond memories of that as well. And we both came back home, and we were really rattled by this whole new discovery of this whole new layer. And we said, we got to try and see what Dr. Dua is saying and whether can we harvest this tissue. And that was immediately after the time when I came back from Dr. Francis Price. Was learning endothelial keratoplasty from Dr. Frank Price, and I was learning DMEC, and I was seeing Frank Price do about 12 to 15 DMECs in a day of his OR. And I was really motivated at that point of time to do this. But then you put in this conundrum where you have PDEC on one side and DMEC on the other. So you're doing both. And how do you combat this? Especially when PDEC is not even a procedure by then. It's just in our heads and it's just functioning in our heads. So I'll just start with where we actually started off uh, this journey. I do have financial interest with LISR, but none of it pertains to the talk today. PDEC as a story or as a uh, surgery is basically started off, as we all know, when the pre-Descemets layer was discovered by Dr. Dua. And it's basically about 25 microns as we know it, and it has a popping pressure, and this is the difference between the two. It's probably given in the books of Ryan and so on, where the popping pressure of this type 1 bubble is 766 versus when you take a DMEC bubble, and I'll show you that the DMEC bubble popping pressure is just 26, and that's where the difference is between the two. And if you see in this image, and I'll just play this video, but if you see the image, the bottom half, like a half moon, that's actually a type 1 bubble, and a type 2 bubble is coming from the side, which is where you really define which bubble you're getting when you're trying to harvest these tissues. I think all over here know it, but I think for the audience sake, it's really helpful to kind of know what the difference is between the two layers and why they are so different. Uh, from a harvest perspective, you have type 1, type 2, and type 3. Type 3 is basically just a mix of both. And you don't really get to use the bubble in that, except if you want to use the DMEC part of it. You can't use the PDEC part of it because the layers are already separated. One of the advantages of using, and I think one of the chief advantages of using the PDEC tissue is basically it's not dependent on any age. You can use this on a 9 month. We've used a 9 month and a 1 year old child as well, the donor. So what that really means is the endothelial count is going to be off the charts, and you're really going to have some amount of pluripotency also. It's not been proven yet, but I'm guessing that that also is an element to it, which really helps in removing scar tissue, removing any vascularization, or so on and so forth. And this is a futuristic view that we have, that we want to at least put it out there in the world, and let's see where it goes from there. This is, I think, some of the electron microscopic images from Dr. Dua himself, but I think you've already seen these. I'll just skip directly into the procedure perspective. This is how we do the graft preparation in images, but I'll show you that in a video. We take a 30 gauge needle, hold the tissue, and we go into the tissue that is a stromal. And as soon as the intrastromal pressure rises to a particular level, you have a central bubble that comes up, and it starts off in the center. Usually we stop at about 7.5 max distance, that is the diameter. We put some trypan blue inside using a knife, and then we manually cut it with a scissor. Is how it's done here. But in the US and the other places where I've gone and taught Site Life how to harvest this tissue, they use a tree fine to kind of they remove the air, and then they tree fine that bubble. And apart from that, now moving on, once the tissue has been harvested and kept, we then move on to the recipient. And I like to use two things, and I'll show that in the video as well. If you see, one is the trocar AC maintainer over here, as well as a tangential light source or a endoilluminator. I'll show you why those two are very important. The air, basically, the trocar AC maintainer passes to me air or infusion the way I want it, whenever I want, whichever I want. So this is a simple pseudophakic bullous keratopathy, and we'll go to the more complex ones later on, but for now let's stick to this just to explain the procedure out. Here's my trocar AC maintainer going into the scleral zone and into my anterior chamber. Again, I repeat, this is into the anterior chamber, not posterior. So the air is basically into the anterior chamber, and it's continuous infusion of air. I make 2 paracentesis wounds, and I'm doing my desmetorexis over here, basically scoring all the way around. And in interest of time, I'm just going to take this a little forward because I know that most people here have already seen this probably in the previous videos, or if not, I'm just going to leave it. It's fine. The idea here is why the light really helps is because you get this view of the margins very, very clearly. More important, once you take out this tissue, you will have some amount of tags left. And those tags act like barriers for the new graft coming in. So you really have to go in and take these tags out. Once all the tags are removed is when you really know that this tissue is now this bed is ready for a new graft to come in. The bed of stromal tissue is now ready. So now I can stop my air infusion and inject some fluid, keep the AC really shallow. Now, important graft loading method, I basically remove the spring from my MIL injector. I put this plunger back, and why I remove the spring is because I don't want this tissue to retract back. I only want it to go in one direction, and the direction that I want it to go is forward like this. And now once it's loaded and ready, I'm ready to, I still have my infusion in place, my trocar AC maintainer in place, and I'm still now starting to load this graft into the anterior chamber. I mean, this next step is pretty much the same as DMEC, except that I don't really wait for all the sides to kind of open up. I do. The advantage of PDEK also is that because of that tensile strength being really strong, as I told you, the popping pressure being 766, it really gives that extra uh, the X factor to the PDEK tissue that you can really iron this out. So it acts like a wet carpet. If you pull a wet, or you just pull a carpet from one side, it's really going to move all the way along. Unlike like a dairy milk tin foil, which basically just tears as soon as you touch it. That's what happens in DMEC tissue, and that's why you're not able to manipulate DMEC tissue intraoperatively. So this is the post-op day 1. This is 3 weeks out, and this is 45 days out into the same eye. And these are some of the changes that we see. Uh, some complex, I would say complications, but really complex scenarios, some complications of previous surgery, and what we do in these complex scenarios. And most of us will find this issue that, we don't know what's inside. This is a really, really scarred cornea / really thick Descemet membrane. We don't know yet. We're going to go inside and find out. More importantly, this is a pseudophakic bullous keratopathy. Most commonly, these occur because there is some instability to the intraocular lens, and the vitreous is somewhere prolapsing into the anterior chamber and touching the cornea. So what I'm doing in these cases is usually making my flaps, ensuring that I do a little bit of anterior vitrectomy, but I can't see much. So whatever I can see is where I'm doing it, my anterior vitrectomy. But more importantly, right now, I'm trying to remove this Descements membrane, which is really thick and really attached, or let me say adhered to the iris. So I really have to even cut away some iris tissue because this Descements membrane has gotten entangled with the iris tissue. So I really have to cut away this iris tissue. And I know probably I'm not worried about the iris right now. I have to worry about first placing that foundation, and I'm going to use that word foundation a lot more. And I see a 3-piece lens. I get really excited if I see a 3-piece lens because I can actually don't need to explant anything. I really just have to externalize the haptics in these cases. So all I'm doing here is basically taking my haptics, doing a handshake technique as you saw me in the previous one and here as well. Left hand, right hand, left hand, right hand. Right hand is going through my sclerotomy that is under the flaps, and I'm now externalizing both the haptics. Once both these haptics are externalized, I make my Gabor Chariot's tunnel and I tuck my haptics inside. But this iris can't be left like this, especially in endothelial keratoplasty, whichever one you choose. You can't leave an iris like this because that air is then going to go only in one direction, and that's south. We don't want that. So we're trying to close that iris defect by single pass 4-throw pupilloplasty. This one move has completely revolutionized or changed the way that we do corneal surgery. Put a IOL in place, whether using the glue or any procedure of your choice, but an IOL as well as a single pass 4-throw has, in these complex scenarios especially, Then I take my harvested tissue, which I'm doing with my trypan blue, and I use the same maneuver as I showed you before to kind of use this and basically put this graft inside and ensure that the graft is in the rightful place. Just in interest of time, I'm going to show you this. I'm not going to show you the unrolling because it's pretty much the same as I showed you before. And this is 15 days post-op. This is 45 days out. And you can see a clear cornea without any sutures, without any, uh, without any, trouble, and a centrally placed pupil as well. Another really difficult scenario to be in when you have to really explant tissue, right? I mean, you have to explant the intraocular lens. And in these cases where you have this scenario where there is a damaged lens, or there is a single piece lens, or there is a foldable lens, which really is tilted in some way or the other. Anything can happen, and you really have to explant. So what you do in these cases is basically put in a trocar, posterior one in this case, do a small incision, small SICS incision, and make your sclerotomies. I'm basically trying to remove this lens. The lens does come out, but as you can see in this case, it's a damaged lens, and that's why probably the vitreous kind of found its way up. Once we found the lens and we removed the lens, there was a lot of fibrous tissue which we had to remove. Also, what I had to do was remove some of the iris that does come out with it. But more importantly, I'm putting my glued intraocular lens in place now. In these scenarios, you can take a call as to doing this in a stage 1 and a stage 2 procedure. And our probable reason for that is I'll explain to you after I finish, where I'm doing some trypan blue. I triamcinolone over here. Once I'm done with my triamcinolone over here, basically I have externalized both my haptics. In these cases, it's rather easier than tough because I'm using a larger wound here. Again, my Gabor Chariot's tunnel come in, and I've tucked my haptics in place. Once my haptics get tucked, I know my IOL is stable, as well as I have now layered a foundation for the endothelial keratoplasty later on. But that's not enough. I always like to make sure that nothing is left behind in the posterior segment. So I do go back and remove any cortical or tissue from the posterior segment. Again, I'm closing my iris tissue here. And if I find a bleed here, and that's one of the most important things to understand, if I find a bleed here in these cases, I like to push the endothelial keratoplasty procedure to the second half, or put it as a stage 2 procedure. But I'm must ensure that you don't do the pupiloplasty later on, because the pupiloplasty can bleed. And how do you check whether endothelial keratoplasty will work later on is this air bubble. You need to place an air bubble and see if that air bubble really stays before the stage 1 gets over. So this is my stage 1 procedure where I'm doing my glued intraocular lens, explantation of IOL, and glued intraocular lens, as well as SFT. So that's done as stage 1. And this is the patient 1 month later. The cornea didn't clear up because obviously the cornea was decompensated a bit too much. Now I'm taking this up as a pure only as a PDEK tissue. And this is a young donor. And when we claim as a young donor, it's below 20 years of age is what we try to get at. And that's the aim that we're trying to achieve, because those are the cells that are really good for these kind of procedures. Again, my trocar AC maintainer comes in. In interest of time, I'm going to go ahead faster. Making my paracentesis, I'm getting my PDEK graft in place. And now once I place it in with my trocar AC maintainer, of course, my graft is injected. And once it's placed in position, do remember there is no vitreous pressure from here. So all that pressure has to be created by the air, number one. And that's one of the reasons that you want to have a small pupil in these cases. You want to have a round small pupil in these cases before you start the PDEK procedure. Once this graft is in place, you can just leave it. And this is how it was 3 months after PDEK. And you can see the cornea completely cleared up. In these cases, this is 4 months. Patient completely achieved 6/6 vision in these really difficult cases. Some tips and tricks that I can tell you for this is basically layer a foundation with glued IOL, pupiloplasty, and use air during your procedure. So that's intraoperative, the last one. And what happens over here is basically if you do push air in, it really holds that pupiloplasty really holds that air, and it tamponates that graft onto the stromal bed that we have here. Another one I can tell you is to use a trocar AC maintainer uh, for better results. And how this is basically helps is it comes into the anterior chamber, gives you a continuous stream of air or fluid. Number two, it is self-sealing in its own way, unless you go through the cornea. So I would recommend go through the sclera at the limbus. That's the right way to go inside. And here you can use your endoilluminator as your third approach. That's a third tip that I can give you. So using your endoilluminator, you can see first, you can visualize which side the orientation of the graft is. This can be done for any procedure of your choice. An endoilluminator using, as well as the endoilluminator gives you that for recipient donor tissue as well. And this is a roll unroll technique of mine, which I basically helps in unrolling the graft. Double infusion really helps in creating that vitreous pressure from behind if you really need it. You can put a trocar even posteriorly that really pushes uh, the iris lens diaphragm all the way up. Supposing the air is not enough, so now you basically push in some air from behind, and it really helps push that complete diaphragm on top, and that way the air is tamponating the graft. Yeah, and closure of the wound. I think everybody over here would be able to, feel me when I say that you have to close well. You must ensure that all your ports are closed properly, and there is no leak of air. One of the tests for that is just constantly push in air, and you'll know where you stand from there. Thank you very much for having me, and I just wanted to say thank you, Dr. Himanshu and Dr. Pooja, for this wonderful opportunity and to have such a good panel, to view this beautiful presentation. Thank you.
Thanks, Ashwin. Thanks very much for being there and taking your time off on such a busy time and schedule of yours. Brilliant. PDEK has always impressed the way you have put it across. I mean, you wonder why should one be doing otherwise? The only way to go about is this. If your safety is so high, the tensile strength is so good, there's no business not to do it. I totally agree with you that the way to go ahead in the future also would be that, Dr. Dua, the way he mentioned and explained the anatomy so beautifully, that how much of a different, it's an absolutely different layer. It's a China wall, which really helps you not to break the Descements open.
Absolutely.
A big bubble open out, so brilliant. This is where it's subscribed right deep into the brain that this is the way to go. Thanks, Ashwin, for being there and making it so lucid and clear. All these steps, friends, what you see are mastered slowly and gradually. What he did are three huge big procedures. PDEK, iris suturing, you need to practice that. Holding two hands, the iris will bleed, it'll tear. You need to do that slowly and gradually. It'll take a little while for you to do. And putting in a SF fixated IOL is not a joke, but you got to do it somewhere. It's fun, it's nice, and a three-piece, what excites him. Your depth of field will change, your shallow chamber will change. Every step which he has mentioned here, he's got two ports going, one behind in the pars plana area, he's got one in the anterior chamber. All these small things which he mentioned are very huge because the chamber collapses, your cornea collapses. If your wound is not good, your lens will fluctuate. You'll think that the lens is falling down in the vitreous. So remember every word, go through it again and again. He's concise, he's gone fast forward, but it might take a few hours to digest every small point which he mentioned. Thanks, Ashwin. That's the beauty of the whole thing.
Thank you, sir.
Rohan?
Thank you so much, sir. Dr. Himanshu Matalia, if he's here, your views on PDEK, and Dr. Vikas.
I told you earlier that sometimes we suffer this kind of thing, that when other person does something, we stop looking at that as one of the option, and I'm different kind of thing. So yes, did earlier suffer that and didn't try PDEK for a very long time. I must say, probably 5 years back maybe, I tried few PDEKs, and it certainly works. Only limitation is that the size, which is smaller. So having said that, learning DMEC and PDEK both can be useful. So you have an option in your hand. Always have option. Never have dogmatic rule in your life that I'm the only person who is right or my technique is only right. So if you have a choice between different things, well, you're lucky. So I'm so happy that the PDEK is one technique where which we certainly can use those younger tissues, and which are very difficult to use for DMEC. So yeah, thank you, Ashwin. We really enjoyed.
Thank you so much, Dr. Himanshu.